Hello and welcome to another episode of Health Matters. I'm your health coach, Dr. Michael Chillemi. Now, I'm going to welcome you back to our fifth and final episode of our ultimate deep dive into osteoarthritis. So, in part one, we explored the anatomy of a healthy joint and followed osteoarthritis from its earliest microscopic changes throughout cartilage degeneration, inflammation, bone remodeling, and pain. Part two, three, and four, we focused on specifically the spine, facet joint arthritis, degenerative disc disease, bone spurs, spinal stenosis, and understanding spinal biomechanics and why they matter so much. Today, we answer the question every patient actually wants to know. What can I do about it? Can osteoarthritis be treated? Can it be slowed down? Can surgery be avoided? What role do exercise have? What role does physical therapy, chiropractic care, medication, injections, surgery, regeneration, lifestyle changes? What do they all have a role in with osteoarthritis? This episode is going to answer all those questions. And at the end, I'm going to walk you through exactly how I evaluate people when I see them in my office and why understanding the structure early often leads to a good treatment plan from Jump Street. With that said, let's jump on in. So, one of the biggest mistakes I see is the assumption that pain alone tells us what's wrong. Pain is only one piece of the puzzle. So, you might have a condition that has a lifespan of, let's say, this. Pain is here at the end. Everything's happened all those years and years and years before that. Pain comes up when things break down. When we look at osteoarthritis, one of the other things that is always remarkable to me is having two patients with exactly the same x-rays, but you have two completely different symptoms. And two patients can describe almost identical pain while having completely different underlying conditions. That's why diagnosis begins with a complete history. I want to understand, when did the pain begin? Did it develop gradually or after an injury? What makes it worse? What makes it better? Do you have any numbness? Do you have weakness? How about tingling down the arms or legs? How about morning stiffness? Difficulty sleeping? Did you have any previous surgeries? And I mean all the surgeries, not the ones that I'm going to find when I take an x-ray and say, hey, Mr. ABC, why do I see clips in there when you said you have no surgeries? Oh, hey, doc, I forgot about that surgery. I didn't know you wanted to know about all. Yes, we want to know about everything. Family history or any other medical conditions. The answers to those questions usually start pointing us towards a diagnosis before I ever lay hands on someone. But it's only one part, right? So your diagnosis puzzle has many pieces, and you got to start putting them all together. That's just one piece of the puzzle. So next comes the physical examination, and this is much more than pushing on painful joints or painful areas. I'm evaluating how the body moves. What's your posture? What's your spinal alignment? How's your walking mechanics, range of motion, your muscle strength, some of your flexibility, your balance? What's your joint motion like? How about neurologically? How are you functioning? Orthopedic tests. All of those provide another piece to the puzzle. So when you're walking into the room and I'm standing behind you, walking you in, I'm evaluating your shoulders. How are your hips balanced? How are your knees? It's my natural thing to do. Doing this now 29 years, you grow to assess everybody as they're walking and standing and sitting, and you're evaluating all parts of it. So I notice, oh, you're hunching and slouching. Your shoulders are slouched, right? You don't sit with your chest up and shoulder straight. You sit slouched. Oh, that could explain A, B, and C. I evaluate constantly. It's just my nature and kind of how I do it. When we're putting the pieces to this puzzle together, sometimes the examination clearly points to a certain condition. Other times it might point to a completely different thing that you didn't think it was going to go into. So sometimes you can suggest disc injury. Sometimes it could be a muscle. Sometimes it could be a nerve compression. Sometimes you could be thinking arthritis is part of it. Often and very often, several conditions exist together. So understanding what you actually look like and what your spine actually look like, what your joint actually look like is important to me. I always like evaluating. If I have a patient that has symptoms that need imaging, I'm going to want them to be evaluated. I think it's important to understand what that spine actually looks like. Now, let me be clear. I'm not suggesting every patient immediately gets x-rays, but when symptoms are there and x-rays are warranted, they're important to be evaluated. I think that understanding exactly what's happening inside your spine or your joints is critical. And x-rays are the best tool to do that. They're the best tool for evaluating structure. It shows us things that the physical exam just can't, right? It's going to show us the joint space. It's going to show us any kind of bone spur formation. It's going to show us the facet joints. And if you have arthritis, how about your disc height? It's going to show us that. Your alignment, your spinal curvature, spondylolisthesis, maybe some degenerative disc changes or end plate changes in the disc. Understanding those findings help us explain why patients hurt. And it helps us build a treatment plan that individualizes the treatment plan instead of being guesswork treatment or okay, this is what we have, go do this. This is my protocol. No, you have to have an individual plan for each patient. Patients tell me all the time, no one has actually ever shown me what's wrong. I think it's critical and important to educate patients. It's one of the most important treatments we can provide. When patients understand their conditions, fear decreases. And when fear decreases, people become far more confident in participating in their own recovery. So when I have patients come back on day 2 and I go over everything with them, I'll go over their exam, um, their history. I'll go over if we took x-rays, we'll go over the x-rays. If I have x-rays, I put them up on a big screen and I show them exactly what it is. If they brought imaging to me, I go over that. If they bring an MRI, I go over that. I want patients to understand what's happening and why we're doing what we're doing and not just doing it because I said so. I'm doing it because A, B, and C. This is the goal we have. This is what we're looking to do. This is why we're doing it. And this is what I'm hoping happens. And if this doesn't happen, then we're going to do this. Right? I want you to be educated because it's important to understand. I think, a lot of times people get told, go do this, and they have no idea why. And to me, I'm like, I want to know why. Why do you want to do this? Why do you want to do that? It's important for me to understand. That could just be me, but I would like to think that if I'm treating patients like my family, right? I want everybody to be treated like I would treat my mother, father, brother, sister, uncle, whoever's in my family. That's how I treat patients because I want them understanding it. It's important to me. One of the other questions I hear all the time, hey doc, just give me an MRI. Let's see what it says. I'm like, no, you don't understand it. An MRI is a outstanding diagnostic tool, but it answers a very different question than X-ray. X-ray is going to show me bone. What about the bone? The alignment, the joint space, degenerative changes, and everything else we already mentioned. MRI is going to show us something completely different. Soft tissue, your disc, your ligaments, the spinal cord, nerves, muscles, inflammation. I typically recommend an MRI when I when I suspect a significant nerve compression or a disc herniation or spinal cord involvement or any kind of progressive neurological defects. Or when we've done a path of conservative treatment and it's not producing the results or the improvement that we expect, right? You've gone on for treating for 6 weeks, no improvement, or we've treated you for 6 weeks, now you're getting worse. We need to figure out what's happening and why. What else is going on that we didn't get, which piece of the puzzle am I missing that I didn't put in there, right? We want to understand that. So we don't want to just treat with a purpose and with a plan of, are you getting better? Are you getting better? You're not getting better? Okay, we need to figure it out. That's why, and when we and I would like to do MRIs. So let's get into the next segment. Can osteoarthritis be slowed down? Before we talk about treatment, I want to answer the question I promised you at the top of this episode. And that, because it's one of the top question people want to know. And a lot of times they're too polite to ask directly. So, is this gonna just going to keep getting worse and worse and worse? Here's the honest answer. We do not currently have a drug, injection, supplement, adjustment, treatment that stops underlying disease process. Nobody does. Anyone telling you otherwise is selling you something. But that is not the same as saying the part of this is out of your hands, right? Like you can't change it because it's out of your hands. Because here's the reality of it. Osteoarthritis isn't driven by time alone. It's driven by how much force goes through that joint, how it's distributed, how well the tissue around it handles the force. And almost every one of those factors is modifiable. So let me give you a clearer example that I know. Every pound of body weight translates to roughly 4 pounds of force through the knees during normal walking. 10 pounds lost is about 40 pounds off that joint with every single step. Multiply that by a few thousand steps a day, and you start to understand why weight reduction is not a lecture, it's mechanics. Muscle is the same story. Quadriceps weakness doesn't just come along with knee arthritis. It predicts it and accelerates it. So weak muscles means more force arriving directly at the cartilage instead of being absorbed along the way. And this is where people get trapped in a spiral, right? The joint hurts, so you move less. You move less, you get weaker. You get weaker, so more force hits the joint. More force equals more pain. More pain equals less movement. It's a spiraling effect, right? That spiral is the thing we're actually fighting. So, to simply answer your question, can we slow it down? We can't stop the biology, but we absolutely can change the mechanics, the strength, the force, the activity level. And in my experience, that changes how the next 10 or 20 years go. Fortunately, most patients with osteoarthritis improve without surgery. But I want to be careful about the goal here. The goal of conservative treatment isn't simply reducing pain, it's improving function, helping people move better, helping them live better, helping them get back to things they've given up on. I want to start here with movement, right? So I want to start here and I really want to be direct about something, even though it isn't the answer you would expect to hear from a chiropractor. If you're if you look at the major clinical guides for osteoarthritis, the American College of Rheumatology, the International OARSI guides, exercise therapy sits at the top, not in the middle, not as an add-on. It's at the top. It has more evidence behind it than anything else we're gonna discuss today, including everything I do with my hands. So, let me tell you why I'm comfortable saying that to you. Because most of the time, my job is what makes exercise possible, right? A patient with acute pain, with a joint that is locked up or fixed up, muscles that are guarding that can't execute through a rehab. It's hard to strengthen them if they're fighting you, right? So we we definitely don't want you to try something and then quit after a couple days because it hurts. We want you to restore the motion first, and then the exercises will become suddenly achievable. And the exercise is the thing that changes patients' trajectory. Now, here's the part that surprises people the most. And we've talked about this. So if you've been with me for one, two, three, and four, then we've talked about this. So cartilage has no blood supply, right? None. It doesn't get fed the way muscles do. It feeds through movement, right? So you compress and release like a sponge, like if you're bending your knee, like a sponge, soaking up and squeezing out. That's what a joint does, and that's how cartilage gets its nutrients. Think about what that actually means. A joint you protect into stillness doesn't preserve itself, it starves. What does that mean? That means if you don't move, your joint starves. Simple English, right? Simple English. So the instinct most people have is it hurts. I'm going to rest. I'm going to lay down. I'm not doing anything. I don't want to wear it out. It's exactly backwards for most people with osteoarthritis. Appropriately prescribed movement is one of the best things you can do for an arthritic joint. It nourishes the cartilage, maintains mobility, strengthens the muscles that protect the joint, and reduces the stiffness that build after sitting. Walking, swimming, cycling, stretching, strength training, the right kind at the right dose for the right person. Choose movement, not stillness, right? So it's all about being appropriate with your exercises. And that's where physical therapy comes right in, right? Leads me right on into physical therapy. So remember what we discussed earlier in the series. Are one of the body's greatest protectors. Every time you stand, walk, climb stairs, lift something, get out of a chair, your muscles absorb the force before it reaches your joint. When those muscles weaken, the joint has to do more work, more load, more force. And for an arthritic joint, that extra stress means more pain, more stiffness, and further loss of function. The goal of physical therapy isn't simply to exercise, it's to retrain the body to move effectively and efficiently. A physical therapist evaluates how you're walking, how you're standing, how your joints move, and where weakness or imbalance is contributing to your symptoms. Treatment focuses on strength, flexibility, balance, stability, coordination, posture, and proper movement patterns. As strength improves, the muscles around the joint start behaving like natural shock absorbers. They stabilize, they reduce strain, they build endurance. Patients notice they can walk further, stand longer, climb stairs with confidence, get through a day without paying for it that night. So one of the biggest things that I have patients tell me, and I always kind of chuckle when I say, "Hey doc, why do I got to do this physical therapy stuff? I go to the gym. It's the same thing." And I chuckle because they just don't understand. And I have to then educate them on, no, it's not the same. And this is why, right? What I just spoke about, them retraining you how to be better patterns, how to stabilize, balance, flexibility, all of that is what they're doing. Very different than you going to the gym. And it might seem a little mundane of some of the exercises, but it's point purpose, right? It's point purpose for a reason. They're there for a reason, right? It's not simply just go to the gym and get on a elliptical machine or go lift this and do that. It's not that simple. If it was that simple, then every person in the gym would not have problems. And I could promise you, we get multiple patients every single week from the gym with arthritis, with disc conditions, with sciatica, all kinds of conditions. So if it was simply just go to the gym and it'll fix it, it's not the case. And that's why going to your physical therapist and being diligent is critical. Okay, let's jump into how does chiropractic and osteoarthritis exist together and what's their role? So as a chiropractor, one of the questions I hear more than almost any other is, can chiropractics cure arthritis? Answer is no. We cannot cure arthritis. No adjustment regenerates cartilage that has already been worn away. No manipulation reverses decades of joint degeneration. And no ethical chiropractor should ever make that claim otherwise. That's simply not how osteoarthritis works. But we can't cure it is not the same as there's nothing we can do. Those are two completely different statements. And people collapse them together all the time because I'm not treating the arthritis. I'm treating everything the arthritis has done to the joint that moves. And that part is very treatable. So when arthritis develops, that joint loses its motion. Small areas stiffen, stiffness develops, right? The surrounding muscles start to tighten to protect the painful joint. Ligaments become less flexible. The joint capsule becomes restricted. Scar tissue may develop, and the nervous system becomes more protective. Over time, the body changes the way you move. Instead of moving normally, people compensate, right? You twist, you walk differently, you bend over, right? You might have that shopping cart syndrome. And those compressions don't stay local. They start affecting the neighboring joints. It's called the domino effect, right? The domino effect. Let's use the lower back as an example, right? If one arthritic facet joint becomes stiff, the joints above it and below it have no choice but to move more. Eventually, those joints become overloaded. The muscles around them tighten. Inflammation increases, and the pain spreads into areas that were never injured in the first place. That's the one reason someone with arthritis in one segment may eventually develop muscle spasms, hip pain, buttock pain, and discomfort higher into the thoracic spine. The body is remarkable at adapting and trying to restabilize and to try to refigure it out. But compensation will always have a bill to pay. This is where chiropractic care can play an important role. So, contrary to what a lot of people believe, a chiropractic adjustment isn't designed to put bones back into place. It's designed to restore normal joint motion, joint function when the motion and joint has been restricted. When a joint moves better, the surrounding muscles often relax. Mechanical stresses decrease. Pressure on sensitive joint tissue can be reduced, and the nervous system starts receiving healthier movement inputs. Patients frequently notice they move more freely, they bend easier, they turn their head further, they stand longer, they walk farther, they sleep more comfortably. Not because the arthritis disappeared, because the joint is functioning more effectively and efficiently. And this is why, in my practice, I don't view chiropractic as a standalone treatment. It is one piece of a larger puzzle and a larger strategy to help with patients. Think of it this way: chiropractic restores motion where motion has been lost. Rehabilitation teaches the body to hold on to that motion through stronger muscles and better movement patterns. One improves mobility, the other builds stability. Together, patients tend to do better than with either alone. Depending on the patient, that strategy may also include postural correction, weight management, nutritional counseling, lifestyle changes, and any other therapies that you could think of, right, that we do. All of that together is to appropriately treat and help protect the joints of you during your daily activity and your daily function. So simply, can chiropractic cure arthritis? No, but we can improve the way arthritic joints function for appropriately selected patients. Absolutely. That's what good conservative care really is. Not chasing the miracle, helping people move, function, and live better despite arthritis. So it's all about keeping motion and movement into the joint, right? We put motion and movement into that joint. We do move the joint. We do take the pressure off it, right? We do that. You hear it. Once that pressure is released, you help restore that function, right? You take that pressure off. That's what we're talking about. So one of the things that's most overlooked in treatments for osteoarthritis isn't found in a prescription bottle. It's lifestyle. We've already talked about body weight and the mechanics behind it, so I won't repeat that math, but I'll say this. Of everything on the list, it's the one with the most leverage over knees, hips, and the back. Nutrition matters too. No diet cures arthritis. Let's be clear about that. But reducing highly processed foods and emphasizing whole foods, fruits, vegetables, lean proteins, healthy fats, adequate hydration may help reduce systemic inflammation and certainly help everything else. Sleep matters. Stress management matters. Not smoking matters. Everything that improves your overall health creates a better environment for your joints. I want to spend a few minutes here because patients ask me about this constantly, and I think it would be a little convenient for a chiropractor to just skip past it. So I won't. I don't prescribe medication. That's not my scope. It's not what I do. And I would never suggest anything otherwise, obviously. But I do talk to and work with physicians who do, obviously, right? So I see the patients who are on medication. So I'm going to give you a little breakdown of what the medication is. So anti-inflammatories work. The NSAIDs, the ibuprofens, the naproxen, and any of those prescription variations have real evidence behind them for osteoarthritis pain. And a lot of people, they're the difference between doing their rehab and not doing it. I'm not anti-medication. Medication that gets somebody moving is doing exactly what it should. A few patients usually aren't told about that, right? It's 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 about being smart about your medication and understanding what you're taking, why you're taking it, right? There are other ones, topical anti-inflammatories are typically underused for knees and hands arthritis in particular, right? The ones that you put on your hands. The topical versions can work very well with substantially less systemic exposure. So if you're taking pills daily for a joint that's close to the surface, your hands, a conversation is worth with your physician about maybe a topical. I don't know. It's possible. Not something I do, but I'm just giving you some of the research here. So the information I'm giving you here is research that I've done, and I'm hoping to put it all together in a package for you to help understand. Again, not my forte, but I've done my research on it. I'm trying to give you what I have for research. Acetaminophen, Tylenol is generally weaker for osteoarthritis than most people assume. It's safe and it's usually safe and easy for most people to absorb, usually with mild symptoms. Obviously, it's not for everybody, but if it isn't touching your pain, that's a a personal failing, right? So the data says it's modest at best for osteoarthritis. And then the part of the matter is that most to me, the real difference between using anti-inflammatories for a flare up and taking one every day for 15 years is the long-term NSAID effect, right? Using those for long-term affect your GI tract, your kidneys, cardiovascular, and that the risk reward, that's up to your physician who's prescribing that medication, not mine. That's up to your doctor. It's a decision that someone should make themselves with that doctor. So here's how I frame it. Medication is a tool for buying you a window. The question is what you do inside that window. If it's used to get you moving, get you strong, get you functional, that's an excellent choice. If it's used to stay comfortable while everything underneath keeps deteriorating, we've only managed the signal and not the problem. Over the past several years, one of the biggest things that have come out is regenerative medicine, and it's been the last 5 years on a incredibly fast growing path in musculoskeletal. Patients frequently ask me about treatments like PRP, um, A2M, or bone marrow concentrate treatments, adipose-derived biologics, and other regenerative medicines. The goal of regenerative medicine isn't replacing an entire joint. Instead, these treatments are an attempt to improve the biological environment within the joint. PRP uses concentrated platelets from the patient's own blood to deliver growth factors that may support healing. There's been a lot of research about A2M, and research continues to be out there, and there's a lot more that needs to be. And there's some promising effects about it, but we're going to wait and see how some of that research comes about. There's been a lot of really good research about A2M and its uh, therapy benefits, but there's not a ton of research on it, so we do got to take it with a grain of salt until we have more. So let me put this next segment, this segment 4, into this. Although most patients improve with conservative care, some continue to obviously have significant pain despite appropriate treatment plans. At that point, additional options should be on the table for patients, whether you have corticosteroid injections to reduce inflammation, hyaluronic acid injections to improve joint lubrication in selected patients, maybe radiofrequency ablation for chronic facet joint pain, and in advanced cases where severe structural damage is dramatically limiting the quality of life, surgical procedures such as joint replacement, spinal decompression, or spinal fusion may be appropriate. Surgery is never a first step, right? It's never the first step, but for the right patient, it can be genuinely life-changing. I've seen it. I want to say something here that I think patients should hear from every provider they see and really do. Part of my job is knowing what I don't treat, right? If someone comes to me with a progressive neurological defect, weakness that's not getting better, that's not a conservative care case. I'm going to spend 6 weeks providing it to myself, right? If you have changes in your bowel and you have bladder problems, that's an emergency. I'm not treating that. That's a phone call to the emergency room. That's not something I treat. When we can't treat something, we're going to refer it out. And understanding those red flags are one of the things that we as providers need to do. And it's important to understand them. So let me tell you I'll leave you with one patient who reminds me why this work matters. So I have a 68-year-old retired electrician that came into my office, convinced surgery was his only option. He's been told he has arthritis throughout the spine and has spent the last 2 years being afraid to move, afraid to do anything, afraid to exercise, afraid to walk around, and afraid of everything he did was making it worse. After we completed our evaluation and we sat down with him, we reviewed his imaging together, went over his history, and explained exactly what we think is happening inside the spine. Something shifted. For the first time, he understood his condition, and the fear started to release. He relaxed a little bit. We began some conservative care, right? We improved his mobility, started getting his strength up, helped do some core stabilization of his spine, modified some of his activities that were creating unnecessary stress. Over about 4 months, he began walking further, sleeping through the night, and that fall, he played 18 holes of golf for the first time in 3 years. Was the arthritis gone? No, it's still there. His x-ray showed arthritis. They're still there. But his life looked completely different. And that's the lesson I want you to take from this entire series. We don't have to eliminate arthritis dramatically to change someone's quality of life. You have to change your thought on what to do with it. Don't be the couch potato. You need to be moving. So I'm going to give you my final thoughts on this. We have learned across these 5 episodes, we've learned osteoarthritis is far more than simply wear and tear. It's a complex biological disease involving every structure in the joint. We've explored how cartilage breaks down, how inflammation develops, why bone spurs form, how spinal arthritis differs from degenerative disc disease, how osteoarthritis contributes to facet joint dysfunction and spinal stenosis. And today we've talked about what to actually do about it. That while arthritis can't be currently cured, it, it can often be managed successfully through education, movement, individualized treatment, and early intervention. Knowledge really is power. It's the most powerful treatment we can offer. The more you understand of what's happening inside your body, the better equipped you are to make good decisions about it. Thank you for joining me for this ultimate deep dive, 5-part series. One of my biggest deep dives I've done. If you found this series helpful, please share it with someone who's struggling with joint pain. Anybody, your mother, your father, your brother, your uncle, anybody you know who's sitting around and saying, I can't do this because of this, and it gets into that spiral effect. Let's break the spiral, get them functioning one day, one improvement, 1 minute at a time. That's what we want to do. We want to improve one. We want to stack those wins, right? We want to keep winning, right? Those little wins, we want to stack them up over time. And eventually you're going to notice, wow, I've done this for 3 months. I'm completely different than I was then. And it was all these little micro improvements. It's important. So, as I always say in my episodes, the information I've given you is my opinion alone. Do not take anything I say as physician or doctor advice. It is my opinion. Please see a qualified professional to evaluate you for what you have. And the thing I always say every episode, the most important thing that matters is your health, because your health matters. I'm Dr. Chillemi. Till next time, be well, be safe. Bye bye for now.